And so we do have some time for some questions or some comments about what next in this realm. Robin. Okay.
Walter, in that 1% that's driving a very large proportion of expenditure, who's in that 1%? I mean, is this like at the very end of life, people's expenditures, or is it the revolving door, the multi-morbidity?
So it's both. It's, and so this is where we have a question. The question came to us, is it true that 1% of the population spend 50% of the hospital spending? And so we did that. And now it's spawned new research. Looking at high spenders, and Therese, one way or another, is looking at, has another project right now looking at this as well. And we're trying to tease apart this. So when we look back, the top reasons for hospitalization come in chronic conditions, but you also see palliative within the top 10 reasons for hospitalization in the prior year among this population. So I think it's, some of it is things like stroke. They're traumatic events that affect a life course. Some of it is the multimorbidity circling back and forth through the emergency departments, and then we have some end of life. And the different populations then will have different capacity to be amenable to change and improvement, right? So some of these I don't think we can do a lot about, but some there are real opportunities where I think an improvement in quality will also lead to a better management of the costs.
Thank you. Please identify yourself.
Larry Chambers. One of the most interesting reports is the physician payment report in 2011 or 12? 12. I just wondered if Walter or anyone else could comment on whether, well, just the magnitude of the impact of that report on the negotiations between the government and the OMA.
I'm going to hand this to the person who's standing behind you.
I'll ask my question now, if that's okay. In answer to Larry's question, just a brief comment on that report. It's been widely reported and obviously widely believed that this report was commissioned by the ministry. It wasn't. It was actually Andreas Lapakis and myself who started this. Was actually investigator-initiated work and started almost 3 years ahead of the negotiations. So that's the number one point. Inevitably, we did speed up the publication process so that it was available, and in fact, the OMA saw it before the ministry, saw the detail before the ministry, so it was shared equally amongst both parties because we realized it was likely to be on the table. My impression, actually, despite the voiced concerns and some of the rather more exuberant publicity around the report, is that it probably didn't have a great impact. And I'm not claiming that as good or bad, I'm just claiming it as fact. And I think the amounts that are being paid were well known to the ministry, was very well aware. Having an independent source, and this makes a point, can be valuable. But I think those trajectories of the two parties were actually well set ahead of our report. Now, I don't think we can claim a direct impact on it. That's my personal opinion. The question I was going to ask, actually, Walter, goes back to this 1% accounts for 50% if it's hospital, or 35% if you include community costs, or whatever that distributional arrangement is. The thing that troubles me about this is I don't know what it should be. I have no idea what it should be, and yet it's a figure that's banded around as though it has some validity. Clearly it measures something, but if we take the extremes, and we've had this discussion, I know your views on this, we don't want hospital costs to be divided equally amongst 13 million people. We don't want everybody to have their day in hospital each year. This is a case where we don't want equity of distribution. So have you, and you've thought about it more, and I know the potential value of it, but do you want to just comment to start with about the values and whether high is good or not? Because I don't have any sense of it.
Yeah, so I think you do know my views, and so this will be a repeat for you. So I think the main thing to me of knowing how skewed the distribution of healthcare spending is is to highlight the value and importance of our healthcare insurance system. And having a universal benefit, because who knows who's going to be in that 1% for many, many of those individuals. Some are a bit more predictable, and that's where I think the real value of the knowledge of who's using the money and how money is being spent in the health system. I don't think it has anything to do with that first kind of distributional graph. I think it has to do with putting the funds and the value up against chronic disease management, up against different optimal care organizations, using it to evaluate integrated care programs compared to usual care, and seeing who in the province is getting optimal COPD management, CHF management, and what the value of doing that is. And perhaps in some cases, as I think we may find in stroke, that setting someone down the optimal trajectory has an improved health outcome, but it also costs more. So those are, I think, the value of having that information. I don't actually think it's anything about that distribution. I think the distribution should be skewed, but I think at a population level, it's not really very meaningful.
So I'm glad to see Reza, because Reza, you rose to the fore. Otherwise, I was going to have to describe your research. So go for it.
Just to add to it, because some of the work this came from is actually a CIHR grant that Walter is on, and Rick and Therese and Jan Barnsley and a few of us, and with Manitoba. This particular work started with some work we did with Manitoba, looking at the distribution of health expenditures, and one of the rationales was there's proposals for medical savings accounts as better ways to finance health care. And what this demonstrated was that that was not a feasible way to finance, because you would be expecting insurers to pick up some very high-cost people in ways that you couldn't quite figure it out. There's been similar stuff looking at in the U.S., and they found exactly the same thing with the U.S., and that's one of the reasons why a lot of the competitive insurance markets aren't working in the U.S. There's been some repetition finding similar work now in B.C. So this type of skewed distribution seems to turn up just about everywhere that one looks at it. As Walter pointed out, there's room for looking at the high-cost people and seeing whether you can treat them more effectively and whether better chronic disease management makes sense. But it's a big argument whenever people try to go in for competitive insurance markets, showing that risk adjustment doesn't do it, because another thing we show with Manitoba is you get the same distribution in every single age sex group.
Okay, well, let's thank Walter for a very thought-provoking